Okay, our second presenter is Cassie Odahowski, a research associate at the Rural and Minority Health Research Center with the Arnold School of Public Health at the University of South Carolina. Cassie, I will turn it over to you. I think even, yeah, get that up.
Hi, I'm going to discuss a project that has been part of our U01 focusing on prenatal and postpartum care. So I am on a team of researchers at the University of South Carolina led by Dr. Peiyan Hung and Dr. Xiaoming Li. And this is one of our projects. Dr. Hung will be discussing some other results this afternoon. So this piece of our project was a starting point to examine state level policies on telehealth during the public health emergency and how that may have impacted uptake of prenatal care services during the pandemic. So national data from Vital Statistics has shown that adequate prenatal care rates did fall in 2020 and 2021 when compared to 2019. However, there were some telehealth flexibility and reimbursement policies that states such as South Carolina took advantage of. Florida is our comparison state for this analysis because they did not take advantage of the flexibilities and reimbursement changes that could have been made at the time. So this is a summary of the telehealth expansion policies that we're focusing on, specifically originating site changes, audio-only telehealth reimbursement, and co-payment waivers. Audio-only is especially interesting to us because Florida does not allow phone call audio-only telehealth services. They only allowed live video. It wasn't until May of 2023 that Florida passed a change to their law to include audio only. Our team published a paper last year that examined technology access for females age 15 to 40, which is the reproductive age, and found that some counties had rates less than 70% of that age 15 to 40 reported having access to a smartphone, tablet, or computer. It's something that I kind of assume everyone has, but that's not true. When we examined that data, there are people in the population that don't have the ability to do a live video call, and not being able to do audio only could have been a barrier for care for those people. So how we constructed our data. This was a retrospective cohort study starting January 1st of 2018 with follow-up through December 31st of 2022. So we have a pre-pandemic comparison, an early pandemic stage, and then a late pandemic stage as well. We used birth certificates from both of our states, Florida and South Carolina. Florida did give us the exact birth date of each child. South Carolina did not give us that in their vital statistics data. So we linked our South Carolina data with all payer discharge data, which had the discharge records for 97% or over 97% of births. We had less than 1% of records that we could not locate in the hospital discharge data without an estimated date of birth, so those had to be removed from our analysis. We also pulled in data from the area health resource file to look at the density of family physicians, obstetricians, and nurse midwives. In some rural areas of South Carolina, family physicians provide prenatal care because of lack of access to OBGYNs. So we wanted to look at those as well. For our analysis, we're comparing our two states that had differing telehealth policies, and we used a Kotelchuk measure of 3 or 4 as to capture adequate or better prenatal care. This is an index score that measures initiation of prenatal care in the first trimester, as well as the appropriate number of total prenatal care visits during pregnancy. It is challenging to achieve the recommended number of prenatal care visits if you don't have first trimester initiation of prenatal care. So it is a measure of both of those pieces. We use an interrupted time series analysis to look at changes in the rate of adequate prenatal care by state. And we compared this by how the population's prenatal care period or their pregnancy overlapped with the pandemic. So we have our first group that is those that gave birth before March 1st. Those are not overlapping with the pandemic. And then we have partially overlapping and fully overlapping with the timing of when they became pregnant related to March 1st. We adjusted for maternal characteristics that we know are related to accessing prenatal care. If you have complications such as high blood pressure and eclampsia, then you're more likely to attend more prenatal care visits. And then, of course, those measures of physician density. We had a very large sample size when we finished constructing our cohort of over 1 million total birth records. We also consolidated birth records for multiples, so twins and triplets were combined to represent one pregnancy. And all of the characteristics of our birthing population for both states differed, with the exception of plurality. So that's, again, singleton versus multiple births. This is just a sample of some of those characteristics. Interestingly, South Carolina had more of the birthing population covered by Medicaid. South Carolina has an expansion of Medicaid that covers people during pregnancy that would not be eligible outside of pregnancy. So we do see an increase in that population compared to our overall population in the state. We also saw a difference in the racial and ethnic distribution, with 30% of the birthing population in South Carolina was non-Hispanic Black, and around 36% in Florida was Hispanic. So our results, we did expect to see a difference in these two states, but when we saw the results of our time series, we were a little surprised at how stark these differences were. Interestingly as well, South Carolina was on an increasing trend before the pandemic, and Florida was on a decreasing trend already before the pandemic. In the early pandemic, starting March 1st, the rates of adequate Carolina were stable. They did not continue to increase, but they also did not decrease, which we think is a win for the state. And while there was a slight change, it was in that later pandemic stage, it was not significantly different from the early pandemic stage. So overall, the rates of adequate prenatal care in South Carolina were stable throughout the pandemic. That was not the case for Florida. You can see a drastic decrease between March 1st and the end of 2020 and the end of 2020, and a continued decrease in adequate prenatal care, reaching an all-time low at the end of our follow-up in December of 2022 at around 65%, which is kind of really not great for adequate prenatal care. Florida in 2021 ranked second lowest in the country for adequate prenatal care, just above Hawaii. Hawaii has geographic challenges that are not present in Florida. So this is a starting point to more closely investigate what's going on in Florida. When we talked with some of our partners on the team who are clinicians, they suggested that there may be an issue of telehealth utilization due to differences in English proficiency as well. We didn't have a measure of English proficiency in either of our data sets for either state, but Florida does have a measure that shows maternal place of birth. So we did a sensitivity analysis to look at US-born versus not US-born birthing people. And we did see a difference in those two. However, the US-born Florida moms still lagged behind the South Carolina moms when it comes to adequate prenatal care. So while this does impact adequacy of prenatal care, it doesn't fully account for, especially those changes that we see in 2021 and 2022 between the US-born moms and the South Carolina moms. So while adequate prenatal care on a national level did decrease during the pandemic, Our results show that that was not universal and did differ by state. So South Carolina may be an outlier, but there haven't been many publications showing state by state comparisons of adequate prenatal care during the pandemic. We also know that there are many contributing factors that weren't captured here, but we would like to look more closely at individual level telehealth use and see how often that individual level utilization impacted the individual achieving the adequate prenatal care. Also, we want to do a follow-up of 2023 data to examine this new audio-only policy change in Florida and rural and racial disparities to see how the pandemic may have affected subpopulations differently and how telehealth utilization may have been utilized differently as well. Thank you.